Good afternoon. My name is Nisha George from the Infectious Diseases Department in Leicester. Thank you for the opportunity to present Down the Rabbit Hole. This was an incredibly challenging case for us, and it was a case of a 68-year-old gentleman who came in with a 6-month history of fever, night sweats, and fatigue, and a 4-day history of bilateral leg and testicular swelling. The only positive history he had was the history of TB contact from his mother. Examination was generally unremarkable, apart from low blood pressure, fever, bilateral pitting edema, and scrotal sac edema, which was confirmed on ultrasound. Chest X-ray was normal. Bloods on admission significantly showed thrombocytopenia, mild anemia, and mild elevation of CRP, but all other investigations were within normal limits. So we did a full-body CT scan, which showed some thickening in the esophagus, stomach, and some terminal ileitis. So we did a gastroscopy and a colonoscopy and took 22 biopsies. But under the microscope, the architecture was normal. Cultures, including TB, were negative. Echo for vegetations, also negative. This was the beginning of what was going to be the most extensively investigated patient, starting with 5 blood cultures, serial malaria, TB, and viral screen, all of them negative. Further blood tests were done, which showed worsening of hemoglobin and platelets, and for the first time, derangement of coagulation. But fibrinogen always remained normal. Blood film was normal, Coombs test was negative, but LDH was elevated, which meant increased cell turnover. For 2 months, he was on IV antibiotics and oral TB treatment, but he never got better, to a point where he needed ICU admission. There, we did further CT scans, now showing mild spleen enlargement. Because he still remained febrile, we did an extensive PUO workup, including niche studies like filariasis, brucellosis, fungal screen, viral screen, also extending to autoimmune screen, myeloma screen, all of these negative. We started him on IV hydrocortisone, and he improved. To the audience, I'd like you to think, what are the possible differentials for this patient at this point? He was set down to the ward and a PET CT scan was requested. Now the edema actually ascended upwards from the legs into his arms and abdominal wall, and now he complained of very vague thigh pain. So we examined him. Now it was really difficult because of all the edema, but I felt that there was a brawny swelling with very ill-defined margins, so we requested for an MRI of the thigh. We did further blood tests which showed worsening of anemia, thrombocytopenia, and derangement of coagulation. So we thought HLH. Though the probability score was only 5%, there was biochemistry to support it, including elevated ferritin, LDH, etc. But bone marrow did not show anything, and flow cytometry was unremarkable. We had so many discussions with rheumatology, hematology, we had lymphoma MDT, and they said lymphoma is unlikely, and the PET CT scan was going to be our best bet. So we did the PET CT, and that showed mild liver enlargement along with the spleen. But interestingly enough, the MRI of the thigh actually showed muscle necrosis with abscesses without any gangrene. So we did a muscle biopsy. These were the series of tests that we did for the patient while he was admitted with us for just over 11 weeks. And as you can tell, it was incredibly challenging. And you have to remember he was deteriorating on a daily basis. And the only positive test was the PET CT and MRI. We did further tests, now platelets into single digits, not responding to any treatment. And EBV, which was previously negative, now came back positive, likely reactivation. The HLH probability score shot up now to 95% with doubling of LDH and ferritin. And bone marrow now showed hemophagocytosis. So HLH was confirmed. We started him on IV methylpred, but what is all of this secondary to? Well, it was secondary to intravascular lymphoma. He was started on chemotherapy by the hematology team, but unfortunately, he passed away. HLH, or hemophagocytic lymphohistiocytosis. I know, it's a mouthful, but it's a very rare and life-threatening condition, and it's a hyperinflammatory response leading to organ damage. Secondary causes are usually triggered by infection, malignancy, or rheumatological issues. And the H score is what we use for probability score because it also incorporates immunosuppressed states. Treatment is high-dose steroids, anakinra, or etoposide as first and second line treatment. This is the H score. Intravascular lymphoma is another very rare condition, and it's the lymphoma of the giant B cells. It's very aggressive, and diagnosis is usually made at the time of death. There are three main variants. HLH variant, also known as the Asian variant, is the most aggressive, with overall survival time being 6 to 8 months, and the treatment is the same as non-Hodgkin's lymphoma. There are three main learning points with this case. Number one, always take a very detailed history and do a thorough examination because that can lead you to the appropriate investigations. Two, always have HLH at the back of your mind, mainly because of the wide variety of triggers, but more importantly, the high mortality rate. Number three, and most importantly, is perseverance. Not every case is going to be straightforward, and any deviation from homeostasis is likely to be a clue. It is our job to put the pieces together. These are my references. Thank you.
Thank you very much. Two comments from myself. Among 88 submissions, we had 5 HLH cases. So it's not that dramatically low. And I want to ask another question. How many of us has post-traumatic stress disorder, PTSD, because we missed HLH in our lives? Let me see whom we asked. Kim Lego.
Hi, thank you, Dr. George. Great presentation. I agree with the post-traumatic stress disorder on all the anytime the rheumatology. I'm a rheumatologist, not a hematologist, so I'm a little bit a bit off kilter from this case specifically. But we do get cold sweats anytime somebody asks us for the possibility of HLH or MAS. I have two questions. One just pertinent to the case. Just wondering why, or if you have any idea about why you only got the diagnosis from muscle. Was there something
That's a very good question.
specific about it?
Yeah.
You answer that one first.
You said
Start with
this-
that. Yep.
Okay, we'll start with that. Okay, sure. So actually, if you look at so there's actually two parts to that answer. So first, if you look at the pyrexia of unknown origin algorithm, skin biopsy is not actually considered as part of the routine. Now, because we know the diagnosis being intravascular lymphoma, we went back and there's multiple case series, including going back to 2003, where infectious diseases consultant from the Mayo Clinic has suggested that if you have a patient with fevers of unknown origin, with spleen enlargement, with either anemia or thrombocytopenia, you should be thinking of random skin biopsies. Now, the caveat to that is random skin biopsies from the series that I've read through, which dated back to 2020 and 2019, they actually say that you need to have a minimum of 3, but the best yield is actually 4 to 6. It has to be around 4 millimeters deep. That's the only way we can get subcutaneous fat, where you can get intravascular lymphoma. But unfortunately, it's never made it into the pyrexia of unknown origin algorithm, so that's how we missed it. 2, this patient never had any dermatological manifestation, so stabbing someone 6 times doesn't make sense. And I think third of all is random skin biopsy, actually the yield, the sensitivity is around 77%. So they say that you need at least 4 to 6 to get the best yield. So the question is, if you get the first 2 false negatives, do you keep going or not? That's why it took so long. And like I said, it was a stroke of luck. He complained of thigh pain. I examined. I thought there was something, so I went for the MRI. I mean, that was the only test we hadn't done yet. So.
And then in terms of the actual treatment for the HLH itself, it looks like they just treated the malignancy. Was there, and steroid, was there any other targeted or specific therapy for HLH, or should there have been in this scenario? Or?
So this is the thing where it starts to get really interesting. So with intravascular lymphoma, there is an actual HLH variant of the intravascular lymphoma. The treatment is still going to be the same, where it's the chemotherapy, or the same as R-CHOP. With the problem with this patient is his platelets went actually down to 3. So things like anakinra, etoposide, and his albumin went down to 18. So they say that with toxicity with etoposide goes up when albumin goes down, and anakinra is contraindicated even with very low platelets as well. So we were kind of, I don't know, as infectious diseases, we just said steroids, hematology, take.
Steroids go.
Thank you.
Professor Natterjee?
Yes. Firstly, I want to congratulate you on an excellent presentation. As PUOs, as we all physicians have experienced, is a nightmare.
It is.
But I would like to ask you, you said that even though you had excluded tuberculosis, you were giving this patient 2 months of anti-tubercular drugs.
Yes.
On what grounds or why?
I think so. From our previous experiences in ID, there have been patients where we've had negative samples even from bronchoalveolar lavage, but a caveat to that again was we've had previous lymph nodes. So by the
You
time
said you had done cultures
Yeah.
on 3 separate occasions.
yes, so we did cultures, we did PCR, we also did bronchoalveolar lavage from the biopsy because of the thickening in the terminal iliitis.
Yes.
We did PCR on that too. Anything that we could grow something from, we tried to grow it. We also went down 16S as well, but nothing. But to answer your question, in infectious diseases, if there's even a slight chance, because he's Indian from Uganda, the probability of TB is always very high. So even if we can't get a proper tissue sample, and if he's deteriorating, we usually start them
But
on TB.
usually we look out for about a month of therapy, and if the patient is not responding by that time, then we shouldn't be going on for 2 months.
Well,
Okay.
thank you for this
Thank you.
perspective. Do we need another question, or could we go to?
Just rapidly?
Go for it.
one?
Let's time rapidly.
Okay, I just want to know, do you think the muscle necrosis was due to vascular occlusion by the lymphoma? What's the mechanistic explanation for the necrosis of the muscle?
I think it's probably because of all the lymphoma cells that was
All right,
right in
so
the
vascular
capillaries.
occlusion.
Yeah,
Thank you very much.
not a problem.
Thank you. We have to move on.